Okay.
All right, so it's started.
Yeah.
All right, wonderful. So thank you very much, Dr. Yogesh Kalkonde, for agreeing to this interview. So I am Dr. Anand Venkatraman. I am interviewing you on behalf of AINA, the Association of Indian Neurologists in America. How are you today?
I'm doing very well, and I would like to thank you for this interview.
Wonderful. It's our pleasure and our honor. We really wanted to hear more from you after reading this recent paper that you wrote titled Stroke Prevention Strategies in the
Mhm.
Developing World.
Right.
Um, Wonderful. So that just came out a few months ago. And I think we'll start off by asking you a few details about yourself. So, what is your background? Where are you from? Like, what sort of training have you gone through?
Right.
What made you pick the current field that you're in?
Right. So, Anand, I was trained in medicine in India,
Okay.
and after doing medicine, my interests were immunology and public health. So
Okay.
diagonally opposite, directions.
Okay.
So initially, I wanted to pursue immunology. So I trained at SGPGI Lucknow.
Okay.
I switched to clinical immunology, and briefly, I was at the National Institutes of Immunology in Delhi.
Okay.
And, I moved to University of Texas in San Antonio
Okay.
to work on immunology, and then switched to neuroimmunology. So started
Okay.
working on the role of chemokines in the brain, and I
Okay.
was interested in the role of non-chemotactic roles of chemokines in the brain. So, my switch to neurology from immunology occurred in San Antonio,
Hmm.
and the reason I love these two systems because they are cognate systems in the body.
Say that again. I'm sorry. I think I missed that word. They are what?
Yeah, they are cognate systems,
Huh.
so they learn. So,
Oh.
like other body systems, nervous system and immune system have remarkable ability to learn,
Hmm.
and that's what fascinated me about both these systems.
Hmm.
So I was pursuing my neuroimmunology that got me interested in neurology.
Hmm.
So I switched to pursuing clinical career in neurology. So
Hmm.
that took me to Baylor College of Medicine.
Okay.
But then I started thinking is I was trained in basic sciences, and during my residency I did clinical research as well.
Okay.
And I was wondering how would I use my research skills. So
Okay.
one option was to continue, doing the basic science research, and
Okay.
the other option was to see whether I could, use this training to help people in need.
Hmm.
So during my residency, I visited a place called Search, where I work right now.
Okay.
And it's a non-governmental organization started by Drs. Abhay and Rani Bang,
Hmm.
and they have done pioneering work using public health approaches to reduce infant mortality.
Hmm.
So I was very impressed with that work, and I could see how power of research can be used to help people who are in need.
Hmm.
So I decided that after my training in neurology, I would come and work in Gadchiroli and work in public health.
Hmm.
So as I told you, my initial interest after training in medicine were immunology and public health.
True. True.
So I finished my training in neurology at Baylor, and for a very brief period, I was a faculty there.
Hmm.
And then in 2011, I moved to Gadchiroli
Okay.
and started working there.
Wonderful.
And so, uh, so one of the challenges I had where I was supposed to look at non-communicable diseases in rural and tribal regions of Gadchiroli.
Okay.
Now, Gadchiroli is one of the most underdeveloped districts of India.
Hmm.
So when I visited villages, I never thought that chronic diseases would be a problem here.
Hmm.
But one of my challenges was to how to identify communities' health problems.
Hmm.
As a clinician, we are trained to diagnose individual patient and identify health issues of that individual.
Hmm.
And in public health, you switch to communities. So your
Hmm.
patient is not individual, but your
Hmm.
patient is community.
Hmm.
So my task was to identify health priorities of a community of 100,000 people
Hmm.
living in close to 100 villages.
Hmm.
So I was struggling as to how would I figure out communities' health priorities.
Hmm.
And one of the frameworks that is used in public health is to understand how people die.
Okay.
So if you understand how people are dying in a community, you get a
Okay.
framework to study, what could be their health priorities.
I understand.
But one of the challenges in rural India is, most of the people die at home.
Huh.
Even as a country, 70 close to 75% of deaths in India occur at home or
Oh,
outside
really?
hospitals. Yeah,
Huh.
and they remain medically uncertified.
Wow.
So as a country, we really don't know what people are dying of.
Huh.
So what we did is we used a method called verbal autopsies.
Huh.
Verbal autopsies is a very interesting tool to look at, what are the causes of death. The way it works is you have a trained personnel who goes to the household where the death has occurred,
Okay.
and then he collects information about circumstances surrounding death.
I see. Okay.
It's like a narration. So there is a narration, and this
Okay.
is by a long list of questions or a checklist.
Okay.
And verbal autopsies have been used in India since 1960s and 70s, and they're also
I see.
used in other parts of developing world where there is no
Okay.
information.
Okay.
So what we did is for 2 years, 2011 to 2013, we looked at what are the causes of death using verbal autopsies.
Hmm.
So when these verbal autopsies are obtained, they are read by trained clinicians,
Okay.
and they read the narration, they look at the checklist, and they give ICD-10 code to the cause
Huh.
of death.
Okay.
And this is done by two separate physicians independently.
I see.
And if it matches, then the data is entered. If they disagree, then it's the other person's code is given to the physician, and they reconcile, or then the cause of death is adjudicated.
I see. I see.
So for 2011 to 2013, we looked at causes of death in a population close to 100,000.
I see.
And what came as a shock was stroke was the leading cause of death.
Really? Wow. That is
Yeah.
very
And
unexpected and very interesting. Hmm.
extremely unexpected. And, I did not come to Gadchiroli to work on stroke, but
Huh.
it was completely serendipitous that stroke emerged as a health priority in this community.
And in case for our listeners who may not have an understanding of why that is so surprising, I think personally my understanding is that stroke is a disease of the developed world, maybe like obesity, hypertension, cardiovascular disease. You wouldn't think that in a country like India, where you don't really see too many obese people, you don't see too much other cardiovascular illness as much as you see in the developed world, that you would see stroke being such a high contributor to mortality.
Yes, so that was a complete shock, and to the extent that I disbelieved the data.
Huh.
So then we started scratching our head as to what might have caused this, and I started looking at population level data or literature as to what could explain this, and so we came across a phenomenon called epidemiological transition.
Huh.
So what happens is, as the socioeconomic status develops or changes, chronic diseases start creeping in.
Ah.
And the first stage of that epidemiological transition is largely driven by undiagnosed, untreated, uncontrolled hypertension.
Ah.
And the obesity phenotype or hypercholesterolemia that you're talking about occurs in the next phase.
Ah.
So my assumption or a myth was that this community in rural Gadchiroli was in earlier phase of epidemiological transition.
Ah.
This theory was proposed by a scientist named Abdul Omran out of UNC.
Okay.
So he calls the first phase of epidemiological transition as phase of pestilence and famine.
Okay.
And so I thought that Gadchiroli was in the phase of pestilence and famine, where infections would be the predominant causes of death.
Exactly. Yeah, that's what I would have thought as well.
Absolutely. And then the next phase is what he calls a stage of receding pandemics.
Huh.
So in stage of receding pandemics, you would have more deaths occurring because of stroke and renal diseases, mainly driven by uncontrolled hypertension.
Ah.
And in the next phase, he calls it a phase of man-made diseases. Then you have high blood pressure and high cholesterol coming in. I like to sum it up as the first phase as a pressure phenotype. and the second phase as pressure and clogging phenotype. So what we have in cities of India or developed countries is a pressure and clogging phenotype.
I see.
What has happened in Gadchiroli is the population has moved to a phase of pressure phenotype or high pressure phenotype.
That is fascinating. Okay. Keep
right.
Going.
So communities are not static, and this is my first learning of public health, that we tend to look at communities as static. They are changing. Their lifestyles are changing. Their life expectancy is changing, and it seems that from what we expected, these changes have occurred really fast. So what we found was that out of total deaths, 14% were because of stroke.
Wow.
And so 1 in 7 deaths in this underdeveloped district were because of stroke.
Wow.
And the the runner-up in terms of leading causes of death next to stroke was tuberculosis at 6%. So there's so stroke caused almost more than twice the number of deaths as tuberculosis.
Oh, wow. And this is in Gadchiroli, which is like one of the poorest districts.
Absolutely. So what we said is, this was really shocking, and we published this in the journal Stroke. Wow. And what we found was that in the age group of 41 to 50, 1 in 9 deaths were because of stroke.
Wow.
And in the age group of above 50, 1 in 5 deaths were because of stroke.
My God.
Close to 90% of stroke deaths occurred at home. So indicating that there was a massive care gap. And then we found that close to 60% of these people who had died had high blood pressure. So that sort of that gave us a hint that high blood pressure is probably increasing in the community. So, but as I said, we were still shell shocked by these findings, and we said, let's look at what's the prevalence in the rural India. So then we realized that there are not many studies from rural India.
True.
And the last study of stroke prevalence was done in 1994, about 10 years, before we started working on this condition. So we said we will go ahead and do a prevalence study. So we did a prevalence study, and since we don't have a CT scanner, we had to rely on WHO's clinical definition of stroke.
Okay. Can you tell us what that is, just so that people like me who don't know what that is?
Absolutely. So, one of the challenges and fun of working in resource poor setting is you have to think hard.
Yeah.
So we said that, how can we figure out, we just have to count people with stroke surviving in the community. So what we did is in a population of 50,000, we trained community health workers to go house to house and use a simple questionnaire, which is developed by WHO, but we adapted it locally.
Okay.
And what it asks is, 6 simple questions. So first question is, has anyone in your household ever developed weakness on one side of the body? Has anyone developed numbness on one side of the body? Was there any facial deviation? And was there any slurring of speech? And if any one of these were present, did they develop acutely? And whether it lasted for more than 24 hours? That's the simple clinical definition of stroke as developed by WHO. So what we said is, can we use this questionnaire? So we pilot tested this in 2 villages.
Okay.
In 2 villages, the trained community health workers went house to house and asked these questions. And then I went house to house and asked the same questions. And if the answer was yes, I performed clinical examination and I diagnosed stroke clinically. So in these 2 villages, we could calculate the sensitivity and specificity. So the sensitivity of this method was 85%.
I see.
And specificity was 99%.
Wow. Okay.
Yeah. So the good thing is that stroke can be easily diagnosed. The clinical manifestations are so stark that you can diagnose stroke relatively easily. So then we took this method and we implemented this method in a population of about 40 villages, which was about 50,000.
Okay.
Essentially, the community health workers knocked on 10,000 doors and asked these questions to the households.
Okay.
And then we had a physician who was trained to diagnose stroke.
Okay.
went and diagnosed stroke. And if he had any confusion or queries, then I went in and examined those patients to diagnose stroke.
Okay.
So here, a neurologist is your gold standard.
Yeah.
So we went in, and in a population of, as I said, about 50,000, we found 175 patients with stroke. That gave us the crude prevalence of stroke at 388 per 100,000 population. So to simplify this, we have 4 people with stroke per 1,000 population. To simplify it even further, we have 4 patients of stroke per village in this underdeveloped region who are surviving. So we have not counted, we have counted dead in a separate study, but this is stroke survivors.
Okay.
So 4 per 1,000 is pretty high.
That is a lot, yeah.
Yeah. So, and when we age standardize it to the WHO population, there is a method to age standardize so that you could compare across different countries. And when we age standardize this estimate to WHO, World Health Organization's population or world standard population, the rate was 535 per 100,000. That's quite high. So ours was the 8th study conducted in India since independence.
Wow.
In a part of the rural part of India.
My God,
Yeah, and this was published in Neuroepidemiology. So these 2 studies, told us that stroke is, leading health priority in rural India, and this was completely unexpected.
Very unexpected,
Yeah, so the serendipity led me to work on stroke in Gadchiroli.
Yeah, stroke in Gadchiroli is not. Nobody would put those 2 terms together, I would think,
Yeah,
if you said cholera, if you said TB, if you said malaria, sure. Stroke, like you would think like you want to be in Delhi or something for that.
Absolutely. So what that also raised a very serious question is that if rural India is going through this phase, then we need to act really fast and start controlling chronic diseases.
Absolutely.
Because rural India is used to dealing with acute illnesses. It is not used to having chronic conditions.
True.
Secondly, it imposes enormous financial burden on people.
True.
So someone who is earning, let's say, 100 rupees a day as a daily wage worker, if he has to spend 5 or 10 rupees per day on medication, then the illness is taking away a lot of monetary resources from that person.
True.
Secondly, if someone as young as, say, let's say in 50s gets stroke, then people don't have social services available to support them.
That is true. Yeah.
If a farmer has a stroke versus someone who is well employed has a stroke, there is hell of a difference in terms of how they cope up.
Absolutely.
So it really concerned us. This is something that we need to address. So that got us into the field of stroke.
Wonderful. And I guess I can now put 2 and 2 together. So that's why you want to focus on prevention, because I assume even in urban centers in India, I think therapeutic strategies for stroke are only now beginning to make themselves kind of understood.
Absolutely.
I heard I have a close network of my classmates from AIMS New Delhi.
Right.
One of them was describing with great excitement about them giving a press release about giving intravenous TPA and performing endovascular thrombectomy on a stroke patient. And this is in AIMS in Delhi. So if you think it is that novel to be doing stroke therapy, then it speaks volumes as to how in an under-resourced place like Gadchiroli, you probably cannot expect to focus on therapy. You must be focusing on prevention.
Absolutely. So, if you look at it as a pyramid, so usually in public health, people love pyramids. So at the bottom of pyramid, you have prevention.
Yes.
And at the top, you have clinical care. So if I would like, the listeners to visualize that out of the total pyramid, let's say there are 1,000 cases of stroke in India. Many of them would end up reaching a stage of TPA or thrombectomy.
True.
Even in the US, people struggle to get in time in the hospitals or come within the TPA window.
Yeah.
So, but the thing is, as neurologists, we are fascinated and we are trained to actually deal with acute strokes.
True.
And I think that, if stroke develops, you are too late.
True.
So I funnily quip that the dilemma I have is, whether I love brain or I love neurology. So if you love brain, you have to start before stroke develops.
That's a very beautiful way to put it. Yeah, go ahead.
So what we know from developed countries though is that prevention has significant power to reduce communities' burden.
True.
So what my stint in public health taught me is not to look at individual patient, but start looking at large communities. So if you look at large communities, you have treatment available and then you have preventive therapies available.
True.
So preventive therapies have enormous power to reduce communities' burden. If you ask a physician, is he more excited to control blood pressure or give TPA? The physician or the neurologist would say he would be much more excited in giving TPA. And I could understand that as being trained in neurology. But at the population level, the dynamics are different.
That's
at
true.
population level, we want to control blood pressure, which is the leading risk factor for stroke.
True.
And studies in Japan and Taiwan have shown that just by controlling blood pressure, they could reduce incidence and prevalence of stroke by 50% over 5 to 10 years period.
Wow.
And that's remarkable. Secondly, controlling hypertension is considered best by WHO, meaning that if you control high blood pressure, you would reduce stroke, you would reduce ischemic heart disease, you would reduce dementia, and you would reduce chronic kidney disease. So one bullet hits 4 targets. And coming from a country like India, where we have generic medicines available.
1 second, Yogesh ji. For some reason, I seem to have lost your video feed.
Okay.
Now you're back. Okay, good.
Yeah. So let me restart with the question, I guess. So what I was saying is that, hypertension control is a best buy because it controls, by controlling hypertension in the community, you could reduce stroke, you could reduce myocardial infarctions, you could reduce risk of dementia, and you could reduce, chronic kidney diseases. So that's why this strategy is called best buy by WHO.
That makes sense, yeah.
Yeah, but so as a country, look, like if I'm working in Gadchiroli, rural Gadchiroli, or rural parts of India or developing country, what are my options? My options are acute stroke care is too intensive for me to provide. But can I focus on prevention? Yeah, definitely I can focus on prevention. But are we focusing on prevention? The answer to that at this stage is unfortunately no. We are not doing adequate efforts to prevent stroke. So it's an interesting problem. We have multiple types of medications available to control high blood pressure.
True.
Being from India, we have good generics available, which cost really, few cents per tablet, or sometimes less than $1 for a month's therapy.
True.
But we are not implementing it. And that's the same situation globally. And even in developed countries, control of high blood pressure is not that well. If you look at countries like United States, only 55 to 60% of hypertensives have their blood pressure adequately controlled.
True.
And only through organized efforts such as the Kaiser Permanente system of insurance, the control went up to 80%. But otherwise, the controls are not good anywhere on the globe. So you have a situation, you have increasing strokes, and for that matter, even within a matter of 5 to 10 years, you will also have heart attacks increasing in rural communities in India as well as in developing countries.
True.
Then you have generic medicines available, but you are not preventing, you're not controlling blood pressure well. So it's a very strange situation. Despite having medications, you are not able to control people's blood pressure. And now, based on the data from the Global Burden of Diseases studies, we know that hypertension is the leading risk factor for death globally.
Oh, really?
Yeah, globally 9 million deaths occur because of high blood pressure. And despite having medications, we are not able to control it as a humanity.
What do you think in rural India, at least, the reason for this poor control is? Is it just that there's not enough doctors or people are not going to the doctors?
Absolutely. So all of what you said. So one thing is, people are not aware that they have high blood pressure.
Okay.
in rural India, they don't have access to blood pressure machines very easily.
That's true. Yeah.
So, and secondly, the rural populations, based on their lived experience, know that they have disease only if they have symptoms.
Ah.
Right? I would not go to a doctor to check. Even for that matter, even urban Indians, if they don't have any symptom, they would not go to a doctor to get checked. So one thing is this probably huge burden of undiagnosed high blood pressure. And the prevalence studies as well as systematic reviews show that in rural India the prevalence of high blood pressure is close to 20%. Some estimates are up to 25% among adults.
Wow.
And the urban estimates are anywhere between 25% to 33%. So rural India is not that far behind compared to urban India. But in terms of availability of resources, rural India has in general very few resources to diagnose blood pressure.
At this point, I think one interesting question that comes to my mind is, when you talk about these things like demographic transition and stuff, based on your experience living there, do you think you can pinpoint what precisely it is that is triggering this? So clearly, if the obesity has not happened yet, there is something else which is happening first, which is making these people get this proto-metabolic syndrome in a way. And then it kind of flowers into obesity, hypercholesterolemia and all that. But what is it that is triggering this hypertension in the first place?
Yeah, one thing is life. And what do I mean by that is people have started living longer.
Oh.
So average life expectancy in India has increased remarkably. So at independence in 1947, the average life expectancy at birth was close to 32 years. And within a span of 70 years, we are at 68 years. So just aging would increase arterial stiffness and increase the risk of high blood pressure. Along with that, there are factors like stress. We often think that in rural India, people should not be stressed. I don't know if only urban Indians have the right to get stressed. But there are too many uncertainties. I mean, in rural India, there are too many uncertainties. If you're a farmer, if it doesn't rain, then all your efforts are down the drain. So an amount of stress in rural areas. You have high salt intake. The food variety that is available is not much, so people spice it up by adding more salt and more spices.
Okay.
The use of tobacco and alcohol is also high in rural and tribal regions. So all these risk factors together push the population towards having more high blood pressure or higher blood pressures.
So, and the latter two risk factors, I'm assuming, have not really changed too much in last 200 years. It's probably maybe just the fact that they're living longer that these things are showing their impact.
Yeah, most likely, I think, in my opinion, it's probably increased, longevity that has contributed significantly.
Wow. That is very fascinating. That's very interesting. And I think, you don't really think of this. It's kind of a disease which is revealed by advances in healthcare, which, are allowing humans to live longer. And then you see that certain other things were unhealthy, but earlier their unhealthiness was not obvious. Now, it is showing up. That is fascinating. Okay. And so what are the other risk factors apart from hypertension control that you think are easy to address and should be addressed?
So first we need to, let me address two questions here. First thing is, what are the risk factors for stroke at population level? Right. And there's a famous study called Interstroke study, which looked at, it's a multi-country study where they looked at, it's a case control design, where they looked at what are the risk factors for stroke. And the leading risk factor, they calculated the risk, they identified a risk factor and they calculated something called as population attributable risk.
Okay.
So what does population attributable risk tell you is, theoretically, if we are to control the risk factor completely, by what percentage the strokes would reduce? Okay. So from the Interstroke study, the leading risk factor for stroke was hypertension. With the population attributable risk close to 47%, and if I may round it up, it is 50%.
So what does that mean? To a layperson, what does that mean? 50% of the risk of stroke in a population is contributed by high blood pressure?
Absolutely. So if you have to control, if you're a population, health specialist, and if you have to control stroke, you would ask what are the leading risk factors for stroke at the population level.
Okay.
And so hypertension contributes to 50% of the overall risk of stroke.
I see. Okay.
Which is good and bad. Bad is because, as I said, the hypertension control, although looks easy, it's not that easy. And good in the sense that it can be easily achieved with, at least we have medications which can be, you can quickly deploy them and control blood pressure.
True.
The second risk factor in the interstroke study was reduced physical activity. Then there were, other risk factors were increased cholesterol, then unhealthy diet. Then you had factors like tobacco, and you have diabetes. But diabetes was at the end, and only 4% stroke risk at the population level was explained by diabetes.
So really hypertension, not getting exercise, and things like smoking.
Yeah.
All of which are easy to control, really.
Relatively easier said. I mean, it's
easier said
than done, but these are really. And so,
Yogesh, your voice cut out again. Sorry. Yeah, just repeat whatever you just said.
Yeah. So as I said, I mean, they sound easy to control, but in practice they are hard to control.
True.
So, when we wrote this review in stroke for stroke prevention strategies in developing countries, one of the questions that came in is are the risk factors different in developed and developing countries? So when we looked at the interstroke study suggests that there are not many differences in terms of developed and developing countries.
I see.
And last year, there was another study from Africa, a case control study by a group called SIREN, SIREN.
Okay.
And they pretty much found the same thing in Africa. So you would expect that Africa, being in an earlier phase of epidemiological transition, would probably have infections or other factors being the leading risk factors, but that's not the case. So based on the interstroke study and the SIREN study, one could say that globally, it seems that the risk factor for stroke, the leading risk factors for stroke are the same now.
Wow, that is very interesting. Sorry, go ahead.
Yeah, so what we did in this review is we looked at what are the risk factors.
Okay.
And then we used the interstroke risk factors as a framework. And under that, we looked at what are developing countries doing to, address the stroke, risk of stroke.
Okay.
It's needless to say that developing countries will initially have to focus on prevention.
True.
And while they are preventing, they will also start gradually building capacity to treat.
True.
So they have to, they have a double challenge of, developing treatment facilities as well as prevention. But as I said, by controlling high blood pressure, you could, in a reasonably short span of time, you could significantly reduce risk of stroke at the population level. Studies in Taiwan and Japan reduced this risk by close to 50% over a span of 10 years, which is a remarkable achievement.
And I think the fact that so much of the risk is contributed by one risk factor is also a good thing in that way, right? Like if it had been something like cancer, where there's like little bit contribution from everything, it becomes so hard to figure out where to start. But here, it's obvious, it's staring you in the face where you must pool your efforts. Fantastic. That's very informative. Now, I would say, so you've told me like other countries are starting to focus on hypertension and they have shown tangible benefits. What do you think? A lot of our audience, of course, is going to be neurologists of Indian origin in the West, and maybe even neurologists in Indian cities. What do you think we can do to assist? Like, because I'm sure a lot of people will hear about your work, read about your papers, and they will feel that they would like to help, but they have their own commitments and families and stuff, so they can't really come to Gadchiroli. But if they wanted to help, like, what would some ways to start?
So, one of the things is to, engage with Indian population. So one of the things is, until I came here, I had no engagement with rural population. So now, after spending 8 years here, I can tell you that I started understanding what are the nuances of healthcare in a rural population. So what happens is we are not trained in public health. So one important thing, if you have to address, the problem of stroke in India, you would need public health approach. You can't just go by, clinical approach. So 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 one thing I would suggest is for the neurologists to engage with centers that are working in underserved, situations. And, every state would have one or two such, centers for working at the grassroots level.
Mm-hmm.
So first thing would be for them to go and understand what it is, like to have stroke in a rural or underdeveloped part of India, and what are the challenges that they face.
Mm.
Secondly, we would, as a community of neurologists, we need to understand public health. So, having public health background will significantly change the way we approach things.
Mm.
So that would be the second thing. And third thing I would say is, if possible, they could get involved with studies that are occurring in rural parts of India. And another thing would be to engage actively with Indian Stroke Association.
Mm. I think that's a very interesting kind of a 4 or 5 pronged approach. I think the one thing I have noticed as well, and I think you see this even in like Bollywood movies and stuff, is that apart from the prevention and the acute stroke stage, the third phase of stroke is of course like the post-stroke rehabilitation and kind of living with those deficits and stuff. So from your perspective, like, can you tell us something about like what you've seen and how you envision this getting better?
So one thing in rural India, or for that matter, even largely in urban India, stroke rehabilitation services have not developed well.
Mm.
But having said that, there is now, more and more interest in urban India to develop stroke rehabilitation.
Mm.
There are some studies are also going on. Dr. Pandian at CMC Ludhiana had recently, conducted a large multicentric trial called ATTEND trial on stroke rehabilitation.
Okay.
The findings were negative, but at least he sort of, this is an attempt to actually go into the area and try and understand it. So we will have to, gradually develop, and, so as a country, we are still looking, or even as a world, we are still looking at good rehabilitation strategies. And as of now, we don't have good answers.
We don't.
And for India, we will have to develop something that is, culturally appropriate, something that is not very expensive, and something that works. So it's a triple challenge of things. And because otherwise, right now, we don't have any rehabilitative services. So what we see in rural area is those with debilitating stroke usually die within first 30 days. And those who survive are essentially those with mild strokes. And we have systematically studied this, and we looked at among stroke survivals, we looked at Barthel index and modified Rankin scale, and that's what we found. Those who were surviving had, close to 50%, 50 to 55% had modified Rankin score of 2 or less. So it's a natural selection at work. So those with debility, they die, and those who have mild deficits survive.
I see.
People do not have any. There are no, organized stroke rehabilitative services in rural areas. So they just, they improve on their own.
It's very sad, because I think stroke is one of those conditions where even once it's really over, like it's not really cured, right? Like if you have, there are many, if you have a heart attack, for instance, it's okay. Unless you're in heart failure, once your heart attack is done, you're pretty much out there back to doing your daily life. But once you have a stroke, everything in your life changes.
Yeah, you are never the same person again.
Yeah. And so when you speak of culturally appropriate strategies, I think one of the things that I'm personally quite interested in is that there is a lot of research coming out of Western universities on Indian, you could say, mind sciences, like, meditation, breathing, pranayam, those kinds of things as tools to control these lifestyle challenges, high blood pressure, those kind of things, and potentially even in rehabilitation of deficits post-stroke and things like that. Do you see a role for that sort of thing in India?
Yeah, so now there is, interest, and Dr. Pandian led, Dr. Sailaja and Dr. Pandian are leading a clinical trial stroke network called Instruct.
Okay.
It is funded by Indian Council of Medical Research, and they are running a trial on yoga for stroke rehabilitation.
Okay.
They are in the phase of recruitment right now. So that would be an interesting study that would tell us about the potential of Ayurvedic treatment or yoga in post-stroke recovery.
Okay, that's fantastic. It's good to hear that people are also starting to explore that for rehab. So I think the other question that I've always been wondering about people like you who really leave behind very comfortable jobs, maybe in cities in the West, maybe, and go to these kind of really underserved areas, is like, what sort of challenges do you usually see people are facing, people like you? And is there some way that you think you would want to make that better?
Yeah, so one thing is, there is no place in the world where there are no challenges.
Okay,
Right? So wherever you go, you will have challenges. They will
that
be
is
of
true.
different sorts.
That is true.
So personally, I think for me it was a motivation. I was always a challenge seeker in my life.
Huh.
So I was seeking, challenges, but I ended up doing challenges where it would make difference to people who need the most, and that's mentally it's a very satisfying thing to do.
Wonderful, wonderful.
So the social sector in India is very rapidly changing now, which is a good thing.
True.
A lot of professionals are coming in the social sector. So highly trained people are gradually coming in.
True.
This funding in social sector in India has increased because of there's something called as corporate social responsibility or CSR.
True.
So through that, the companies that have a turnover above 1,000 crore are like sort of supposed to put in 2% of their profit into social sector, and so through that, the field of development in India has become very exciting field to work in.
Huh.
And government is also gradually opening up to ideas, and especially in places like Gadchiroli, you could work with government, and government would be open to certain ideas. So I think the field, India, rural part of India is now undergoing a significant change, and there are a lot of, I personally believe this is an exciting time to be there. There are challenges, but again, as I said, there are no places or no place in the world which is without a challenge.
Absolutely. That is a very insightful statement. And I'll reveal to you personally that I am personally very interested in this sort of stuff that you're doing. So I myself am a neurologist. I'm a neuro ICU fellow, and I'm going to be training in neuroendovascular procedures as well after this. I'm also very keenly interested in the concept of telestroke and teleneurology that they have here, which I really see the power that this technology has to take the neurological expertise concentrated in one place and just broadcast it to like 500 miles away, whatever. So, and I really feel like, at least at this time, I am exploring my options in terms of taking these skills back to India at some point in the medium term. So it's good to hear from somebody like you that it is an exciting time. And I know there are many people like me who also share similar views. And I think really telemedicine is going to be very helpful in surmounting the challenges in places like India, where like I've heard that 50% of Indian neurologists are in like, I don't know, like 8 metro cities or something.
Absolutely.
Yeah.
I mean, even some people call it 70-30 paradox. So 70% of India's population lives in rural area, and it has 30% of doctors.
Wow.
While 30% of the urban population has 70% of doctors.
That is wonderful.
There are different innovative strategies that we could address. And again, the analogy of pyramid is very useful here. So at the bottom, we have a large chunk of prevention.
Okay.
We have, then we have acute treatment, and then we have specialized treatments.
True.
So, prevention is something that has to be done at the community level, and that's a very empowering phenomenon for the communities.
Yes.
So in 2016, we started a large cluster randomized control trial, which is funded by the Wellcome Trust and Department of Biotechnology of India, where what we are trying to see is by screening the community for high blood pressure, diabetes, and stroke, and then community level treatment of these individuals, would we be able to reduce stroke deaths? And it's 3.5 year long trial. And finishing this year in December.
Okay.
We are trying to see whether at the community level in rural, underdeveloped setting like Gadchiroli, whether we can control blood pressure and diabetes and can provide secondary prophylaxis of stroke with atorvastatin and aspirin. So you have, irrespective of brain imaging. So, if someone has stroke, doesn't have, loss of consciousness or seizures at the onset, we are giving these patients low dose atorvastatin and aspirin. And so you have a large chunk of the bottom of the pyramid where you could such community-based strategies which are driven by community health workers work. Then you would come to sub-district hospitals or district hospitals where having acute care in the form of simple acute even stroke units would improve the level of care. And then through district hospital, you could run a telestroke program, say by tying up with the sub-district hospitals or rural hospitals as they're called in India.
True.
And then, for cases which are really need expert intervention, you would have such facilities at the level of larger medical colleges or eminent institutions.
True.
So it would be a tiered approach of stroke, and we have to fire at all levels. But if you ask me in terms of prioritization, I would prioritize the community level approach first, because it strengthens the community, and just by giving simple preventive therapy, you could significantly reduce the burden that would come in. Otherwise, if you start admitting every patient with stroke, it would be onslaught on the hospital.
That is absolutely true. It would overwhelm the resources, and honestly, even here, like in Boston, where there's so many neurologists and stroke doctors, I know a lot of people are moving towards studying the role of social networks and dynamics in risk as well as recovery from stroke.
Absolutely.
I think one of the guys here, like one of the popular papers he wrote, like not too long ago, a year or two ago, was the communicable nature of non-communicable disease.
Absolutely.
I think it came in the Lancet or something. So it was very fascinating, and it's good to hear that you pretty much have the same view on this.
Yeah, and especially the experience of last 2.5 years in the trials, in our trial, has really sort of, I understood the power of community health workers. So, and the power of primary health care. So our trial is going to be, I mean, I'm very excited about the trial because it is first of its kind in the whole, world, rural part of whole world. And that's why it was funded by the Wellcome Trust.
Wonderful.
So we would see whether, we could significantly reduce stroke deaths in such resource poor setting.
Fantastic. That is very exciting to hear, Dr. Yogesh. And I think I have kind of asked you all the questions that I had. Do you have anything in particular that you want to tell our listeners, other than what you already told us?
For someone who's working in rural India, I'm always like in search of people who would want to work in rural India.
Okay,
rural India needs brightest of brains, and
yes,
I usually tell people that I look at problems in rural India as cognitive challenges. Right? So when I work in rural India, I have to constantly think.
True.
It's too much pressure because I don't have resources, so I have to constantly think and figure out things. So we need to, look at, challenges in rural India as puzzles to be solved. And I don't like to call them problems. I like to call them puzzles because there's a whole lot of excitement when you solve puzzles. And if you just call the same thing problems, then you get tired.
That's true. So, that's a beautiful way of putting it, like kind of like being in a game.
Exactly. So that's how I see it, and that's why I enjoy what I do every day. So what I would say is that if I would request that if you could engage with rural healthcare, it would be a remarkable experience. These are all bright minds who are working in the US, and the training in the US is amazing. But at the same time, I mean, you could also be someone who can do primary care. So sometimes by compartmentalizing ourselves or specializing ourselves, we reduce our impact or our footmark. So these are very interesting challenges, and by taking public health or community health approach, you could solve such problems. So this is I would like to put this challenge up to bright neurologists in the US that think of it as a puzzle and start taking up challenges.
Wonderful. So on that note, would you like to share some sort of contact information for yourself so that people who are interested can, reach out to you?
Yeah. So my email address is yvkalkonde@gmail.com. Or if you could just search me on Google, you would come across my contact. I work for an organization called SEARCH, SEARCH in Gadchiroli. It's a world-renowned organization. And you would also find way to contact SEARCH, and through that I can be contacted.
Wonderful. And I believe Search recently was awarded the Padma Award or something, wasn't it?
Yes, our founders, Dr. Abhay and Rani Bang, were awarded with Padma Shri last year.
Wonderful. Yeah, it's very heartening to note that people are giving them their due. And I think it won't be long before you join their ranks as well. But I think that's all I had, Dr. Kalkonde. Thank you very much. It was wonderful speaking with you. And I hope to be able to hear more about this fantastic work that you've been doing. Thank you.
It's a pleasure, and I would like to thank AINA for this opportunity. And I would also like the listeners to go ahead and read that review that we wrote in Stroke about stroke prevention strategies in developing countries.
Absolutely. All right. Thank you. Bye.